My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation in Michigan. Our Learn and Share conference call today is on mood disorders and epilepsy, and we're very pleased to have with us Dr. Adriana Tanner, who is an epileptologist at Mercy Health Hauenstein Neurosciences. Dr. Tanner, can you please introduce yourself and give us a brief overview of your clinical and research interests, along with your experience with this topic?
Yeah, thank you. So first, thank you so much for inviting me again. I'm thrilled to be here with you today. I'm a neurologist and I specialize in epilepsy. I'm the medical director of the Epilepsy Center at Hauenstein in Grand Rapids. I've been here for about 8 years. My clinical and research interests are around treating women's seizures in epilepsy, treating seizures in elderly, refractory epilepsy, treating individuals with intellectual disabilities, and mood disorders. I've actually been interested in mood disorders and epilepsy for quite a while, and I am a big proponent of treating these disorders aggressively. So I'm glad to be able to share some of that with you today.
Great. So just for everyone who may not be familiar with the term mood disorders, that includes depression, dysthymic disorder, bipolar disorder, and a few others that are in the DSM, but we'll focus on those three. Can you give a brief overview of the symptoms and diagnostic criteria for each of these disorders? And
Sure.
We'll look at it in terms of the general population, then we'll look more specifically in terms of epilepsy afterwards.
Correct. So for major depression, for someone to be diagnosed as having a major depressive disorder, patients have to have 2 or more major episodes. And these are episodes where patients have at least 5 of the following symptoms. So usually depressed mood most of the day, so feeling sad and blue, diminished interest or pleasure in activities that normally a patient would enjoy, changes in weight, insomnia, sometimes agitation or just sort of psychomotor delay, fatigue, loss of energy, feeling worthless or feeling a lot of guilt or decreased ability to concentrate. Sometimes that can come with recurrent thoughts of death. Now, patients don't have to have all the symptoms, but these are in general some of the symptoms that they present. For dysthymic disorder, it's sort of like a smaller representation of depression, and patients usually have poor appetite or overeating, insomnia or sleep too much, low energy, low self-esteem, poor concentration, and sometimes that comes with feelings of hopelessness. Now, for bipolar disease, we have 2 sort of different categories. Bipolar 1, in which the primary symptom is manic or rapid cycles of mania and depression, or bipolar 2, in which the primary symptom is more of the recurrent depression. But patients have hypomanic episodes, which is really a milder state of a manic episode in which the symptoms are not as severe, although there's some social impairment. So manic episodes, patients have increased self-esteem, they have decreased need for sleep, they're more talkative, they have a lot of ideas, they're very distracted, and they have excessive involvement in a lot of activities like gambling, buying, etc.
Okay, and with bipolar 1 and bipolar 2, is one more prevalent than the other in the general population, and is there any difference in prevalence in people with epilepsy between the 2 types?
I think bipolar 2 is more common, and that's also reflective in the epilepsy population.
Okay, great. So estimates vary in the literature, but can you tell us roughly what percentage of people with epilepsy experience depressive disorders or bipolar disorder, and then how does this compare to the general population?
Yeah, and this is really the most important matter we'll talk about today. A few decades ago, we really didn't know much about this, but studies show that anywhere between 30 and 60% of patients with epilepsy suffer from mood disorders. I think the numbers are closer to the higher end of them, so about 50 to 60%, which are really, really big numbers. If you compare that to the general population, for the general population, the numbers are around 2 to 16%. So there is a very, very significant and statistically significant difference between the two groups.
Right, and it's not simply a matter of dealing with a chronic illness, because when you look at other chronic illnesses, they don't have as much of the increase in prevalence as you would see with epilepsy. Is that correct?
Correct. I mean, we see in some other neurologic diseases similar numbers. For instance, I can tell you we're looking at similar data for Parkinson's disease, but it's definitely not just because of a chronic issue. And something we'll talk about later is this sort of bidirectional relationship between both illnesses. But I want to give you an example of one of the early studies we had was precisely trying to answer the question if patients were depressed just because they had seizures and the seizures were not controlled. But they looked at patients that were both in remission, meaning they were taking medications and had no more seizures, versus patients with really refractory seizures. And equal numbers of patients in both groups had depression. And it was one of the earlier studies that surprised us in the sense that we realized that it was not because patients were having seizures or were disappointed with the control. It was regardless of the seizure control that patients had these mood disorders.
Right. So in relation to that, are there particular types of epilepsy or epilepsy-related risk factors that further increase the chances of having a mood disorder with epilepsy?
Yes. Psych disorders, especially mood disorders, have been really recognized in patients with both generalized and partial epilepsy. Most of the mood disorders have been associated with seizure disorders that are of focal origin. However, and those are mostly with frontal and temporal lobe epilepsy, and I'll go back to that. I have to say that for a while there was this sort of false impression that patients with primary generalized epilepsy didn't have any mood disorders, but they do have some psych disorders. They tend to be, a little different. Some of these patients have more difficulties with concentration, executive decision making, some hyperactivity, impulsivity, aggression, etc. But they're definitely there. In patients with seizures of focal origin, then they tend to have more of the typical mood disorders like depression, anxiety, bipolar, etc. So there's definitely a difference. In terms of risk factors, it seems that poorly controlled seizures, like intractable seizures, might represent a risk factor, as well as having to take more than 2 or 3 medications at a time.
Okay. And we discussed earlier this bidirectional relationship between mood disorders and epilepsy. Can you explain what that means, and then what some of the possible biochemical and structural and functional abnormalities may be shared between both epilepsy and mood disorders?
Correct. So what this bidirectional relationship means is like it's a street with like 2 ways. And so basically depressive disorders, like the data suggests that not only epilepsy patients are at a greater risk of experiencing psychiatric disorders, like I mentioned earlier, but it also seems that patients that suffer primarily from psychiatric disorders are at greater risk of developing epilepsy later in life. And that's what the bidirectional relationship means. Again, one of the earlier studies was the one that I mentioned earlier. And what they suggested is that some of the same mechanisms that produce seizures can produce the mood disorders. And so there's actually some of them that have been investigated. And I think this is still a work in progress, but some of them have to do with hormones and something that we call the hypothalamic pituitary adrenal axis, which is intimately linked to the temporal lobe, hence this relationship between temporal lobe seizures and depression. Another big theory is about serotonergic, about specifically 5-HT, serotonin, and how it can be deficient in patients with epilepsy and is also deficient in patients with depression. Yet another mechanism has to do with GABA, which, by the way, is affected by some of the seizure medications, as well as noradrenergic receptors. So there are a number of mechanisms, but what I tell my patients is that a good way to understand this is, again, that some of the same mechanisms that produce the seizures can produce depression and vice versa. So they often come hand in hand.
Right. Okay. Can you discuss the various ways in which depression and bipolar disorder can make the symptoms of epilepsy worse, and then also how epilepsy can exacerbate or make mood disorders worse?
Right. Well, first and foremost, the one thing that we worry about the most with depression and bipolar and anxiety with epilepsy is that when they come together, quality of life really suffers. This is something that, again, there's been numerous studies looking at specifically quality of life indicators, and they really worsen quality of life. And that might sound like an obvious response, but it is oftentimes perceived as that by patients. Sometimes these individual problems are looked at just separate issues, but again, when they come together, they can really impair quality of life. Now, when you put together depression or bipolar disease or anxiety and epilepsy and perhaps older age, then those quality of life indicators go further down. By the same token, if you put together mood disorders and epilepsy and intellectual disabilities, again, the quality of life is extremely poor. So there are a lot of ways that the symptoms can be worse. Other ways are that, for instance, patients with anxiety, bipolar, or depression can have very poor sleep, which is actually part of the symptoms of depression, and that can result in increase in seizures because of sleep deprivation. There are a high percentage of patients with depression and mood disorders can end up engaging in the use of recreational drugs, which may increase also seizures. Some patients feel hopeless, and sometimes they stop taking medications. What's the point? I'm not going to get better. And that can lead to more seizures. And some patients may feel just some cognitive difficulties because of medications. So there are many ways where they can interact. Now, in terms of epilepsy exacerbating mood disorders, I think the biggest one here is isolation and stigma, that they can really worsen the symptoms of depression. This is really unfortunate, and it is something that as a society we should definitely try and do better and protect patients from feeling that way. A lot of times medication side effects, and I think we're going to have the opportunity to talk about this in more detail later, can further worsen the symptoms of depression. I mean, definitely some of our seizure medications can cause behavioral difficulties. So the interaction is not only at the molecular level and at the mechanism level, but also in terms of symptoms, there are a lot of interactions.
Right. Okay. So can you talk about how depression, dysthymic disorder, and bipolar disorder might present differently in people with epilepsy as compared to the general population? And do some mental health professionals who maybe aren't as experienced with epilepsy sometimes fail to diagnose mood disorders because they don't fit the textbook definition in patients with epilepsy? Yeah,
I think there's a couple of groups. Some patients present with classic symptoms of mood disorder, depression, and anxiety. And so they really don't differ that much from, like you said, the textbook recommendation. I think the biggest issue for these patients is that they're not recognized because an unexperienced healthcare provider may simply disregard these complaints as being part of the epilepsy. And to me, that has been historically the biggest issue. And I think a lot of times patients themselves think, it's their fault and I'm just sad because my seizures aren't better. and they don't necessarily voice, these concerns. And so in my view, these complaints are very often dismissed. And I think that's why they're not always diagnosed not only properly but in a timely manner. Now, we also know that some patients with epilepsy will not present with typical symptoms, and what we will see will be more subtle behavioral changes, irritability, subtle changes in mood, changes in sort of their social interactions, aggression, isolation, and so it's not the typical symptoms that you can pinpoint, and therefore, again, I think very easily are dismissed. So this brings me to the point that I think patients, and again, those of you listening, you are your best advocate. If you feel that this is outside what you should be experiencing, you need to bring that up to your primary care physician, to your neurologist, to your epileptologist.
Right. Is there any difference in terms of how consistent the symptoms are? Because sometimes they can be related to seizures themselves. So if you've had a lot of seizures, you might be experiencing greater symptoms, or if you have been seizure-free for a while, maybe you have periods that are symptom-free. Does that ever interfere with diagnosis in terms of the typical definition or diagnostic criteria?
Right. I think that's a great question. And some of the things that we've done a lot of studying in epilepsy is that some of the symptoms are depend upon or are timed depending on when they occur in relation to seizures. So we know about the pre-ictal symptoms, which are the symptoms that precede a seizure, the ictal symptoms, which occur during the actual seizure, and then the post-ictal symptoms just following a seizure. We also have interictal symptoms, right, between when patients are not having any seizures. So the pre-ictal usually occurred a few hours before, and I think this is something that we see very often. And a lot of families will tell you, we know that he or she is about to have a seizure because a couple of days before she becomes really irritable. And I don't see a pediatric population, but I know that a lot of parents will say that about their kids. I know he's about to have a seizure. I know when my child is about to have a seizure because a day or two his mood changes. So that's something that has been very, very well recognized. During the seizures, we can see things such as depression, fear is a very typical, or a panic. Some patients even present with sort of sensations that can be reminiscent of pleasure. Some patients have very religious thoughts, but we think that's an actual ictal phenomenon, meaning this is related to the seizure. But perhaps the ones that we know most about are the post-ictal symptoms, and I think all of us have heard about psychotic episodes or belligerence or irritation after the seizures. And that can last for a while. That can be days after the seizure. And then we have the symptoms sort of in between. Again, on your experience with this, someone may say that's because you just had a seizure. But I think there are symptoms that can be seen, and what I do is I try to classify them according to when they happen around the times of the seizure.
Okay. So with this in mind, what do you recommend for patients with epilepsy who are seeking an assessment for depression or bipolar disorder? Maybe they've experienced some symptoms. What type of professional should they see? Should they see the neurologist first? What should the neurologist's involvement be throughout the process?
Well, in an ideal world, I think patients should be able to bring that either to the neurologist or primary care physician and should be able to see a psychiatrist. I think that that's an ideal world because it's hard to find, at least in the areas where I practice, not only here in West Michigan, but where I practiced before in Ohio, it's really hard to get to see a psychiatrist. So I can tell you what I do in my own practice. I encourage patients to discuss that with me. We do assessments for that in our office. And I see more and more now neurologists and especially epileptologists are treating patients for that. And I can tell you I treat my own patients for depression and mood disorders. And I think every neurologist should be able to at least initiate the treatment, give you an antidepressant or give you something for anxiety. My policy is that if that doesn't work, if you've tried maybe a couple medications, then that's maybe a good time to see psychiatry. But I think the bottom line is bring it up to someone, ideally to your neurologist, if not to your primary care physician.
Right, okay. And the other reason you'd want to mention it to your primary care physician is that there could be a physical cause for it, or it could be related to another as of yet undiagnosed health condition. So that would buy.
Absolutely. And when we see depression, especially as we age, I think there's a number of things that can cause depression. I mean, for instance, as we age, dementia can present as depression or with signs of depression. For all ages, thyroid disorders can present initially as depression, hormonal changes, deficiencies, etc. So absolutely, this is something that always needs to be ruled out. Very good point.
Okay, great. And when diagnosing mood disorders in patients with epilepsy, how can you distinguish true symptoms of depression or bipolar disorder from anti-seizure medication side effects? Because many of them can cause those types of symptoms.
Great question. Well, first of all, is like in everything in medicine, the history is a key element here. When I assess patients for depression, I start with family history. Was there a history of mood disorders, depression, anxiety, bipolar in your parents, in your siblings? And then I also go back to when the symptoms started. A lot of times we will see that when you ask patients and when you actually start inquiring, a lot of patients will say, you know what, I think I had some of these symptoms as early as adolescence. So if they've had that and then a medication is recent, it's more likely that it is the mood disorder and not the medication. It is tricky when patients don't recall having symptoms and we only see the symptoms as we start the medications. Then it's tricky because it's not always straightforward to tell which is which. There's some cases in which it's obvious. For instance, a patient that has never had any difficulties with mood disorders and depression and is put on a medication such as levetiracetam or topiramate, and the patient immediately has episodes of anger and irritability. I think it's easier to say this is probably medication, but it's not always as simple. Right. A lot of times when these symptoms are not clear, it is worth to maybe switch medications and see sort of if you remove a medication that is known to produce behavioral side effects from the equation, if that changes things. But again, for a lot of patients, a good history will tell you when the symptoms started, and a lot of times they've been there for years.
Right. Now, I remember reading at some point that anhedonia, which is that inability to experience pleasure or the loss of interest in things you once enjoyed, that is unlikely to be a side effect of medication. Have you ever read that or heard that before? Yeah,
I think that's true. The most common psych adverse events of anti-epileptic medications are irritability, aggressive behavior, a lot of times hyperactivity. More so in patients that are intellectually disabled. I suspect a mood disorder more if the patient gives me a history of more of a sort of cyclic pattern of symptoms going, and if they have neurovegetative symptoms, which are the sleepiness, what you just mentioned is called anhedonia, the lack of, the changes in the eating habits and all that. So that is a good point, and then always remember to check. I always remember to check for family history, but that is a good way to tell sort of which is which, definitely in these patients.
Okay. So we don't have time to get into all the intricacies of medication-based treatments for mood disorders. That could be an hour-long session in itself, but is it possible, though, for mood disorders to be treated effectively with medication without significantly increasing the risk of seizures and with manageable interactions with anti-seizure medications?
Yeah, absolutely. Yeah, I didn't want to spend time talking about individual medications, but I can give you just a brief overview. So the first line that we have, I think, are two groups of medications. One are called SSRIs, selective serotonin reuptake inhibitors, and the SNRIs, serotonin norepinephrine reuptake inhibitors. And I think every neurologist should be able to prescribe one or the other. These are medications that have very good efficacy for depression and mood disorders and anxiety. Again, without going in detail of which is better for what, some are better for anxiety than for depression and vice versa. But as a general group, I think they're very efficacious. They are somewhat clean medications without tons of side effects. A lot of times when I talk to patients about antidepressants, patients have this idea that sort of the old benzodiazepines, Valiums, and Largactils, and medications that would make them drowsy and like a zombie, and that's really not the case for these medications. In fact, sedation is not commonly reported. Most patients get sometimes a little nervous at the beginning, and then they tend to tolerate the medication very well. A few side effects are reported, a little bit of dizziness. Like I said, some anxiety the first few days, also some insomnia the first few days that usually gets better, and some patients experience sexual side effects. But for the most part, very well tolerated medication. So I would say that that's the case for these two groups. I usually start patients with an SSRI, and just to give you an example of what some of these medications are, the first generation of SSRIs were, for instance, Prozac. Everyone has heard of Prozac. The second generation were medications like Zoloft. And then the later ones are medications like Celexa or Lexapro, which are, I think, really good. And then for the SNRIs, we have medications like Effexor. I usually start with one, and if it doesn't work, I move to the other one. But a lot of patients, about 50% of them, will respond very well to the first medication. There are, for patients that have frank sort of psychotic symptoms with the depression, then the atypical antipsychotic medications are okay to pick. We tend to avoid clozapine because it can increase seizures, but I think beyond that is something that you have a conversation more with a psychiatrist than with a neurologist.
Okay. But, of course, a neurologist should be in the loop in terms of any potential for interactions or increased seizures.
Absolutely, yeah.
And
so we can talk about those risks if you want to.
Sure.
I mean, can I? Sure. So, and I think you wanted to talk about that, and perhaps the biggest risk is that of increasing seizures. And I always discuss this with my patients when I prescribe these medications, because when you open the package insert, the first thing you're going to see, well, maybe not the first, but second or third, is that something that says that it may increase seizures. And I always tell patients, no, I'm not crazy, and don't think I've lost my mind. And basically what happened when we first started using these medications and when they were being tested, there were some cases of seizures. If you look back at the trials, what you will discover is that the patients that had seizures were patients that took large doses or that overdosed on it. And so in reality, we think the risk associated with antidepressants and mood disorders in patients with epilepsy is minimum. And I'll give you an idea what that is. For medications like Prozac, it's about 1.2%. For Zoloft, it's about 1.7%. For the newer ones, it's about 0.4%. So less than half of a percentage point. So fairly safe. Some are really not recommended. And for instance, a medication known as Wellbutrin or bupropion, then that percentage is much higher. So it takes about 3 to 4%. So we don't recommend that. But in general, don't be afraid to ask about that, because a lot of patients look at the paperwork and like, well, what is this about? I don't want to have more seizures. But I think, in fact, they are safe. And not only they're safe, but research suggests that treating the depression will make treating the epilepsy easier and better.
Right.
But again, and we go back to, remember we talked about how these conditions share mechanisms. If you treat the depression effectively, you may get better control of the seizure.
Right.
So not only they're no risk, I think they're safe and they're important.
Okay, great. And if someone with epilepsy is diagnosed with bipolar disorder, do you sometimes consider switching them to an anti-seizure medication that's also a mood stabilizer if they're not already on one?
Yeah. The short answer is yes.
Okay.
And that's one of the greatest things that we have about having so many drugs in our armamentarium. About 2-3 decades ago, there were only 3 or 4 medications we could use. We now have 16, 18. So I think that's great. So the short answer is yes. The long answer is that's not always possible because a patient might be controlled on a certain medication. Then switching medications, as you know, is not necessarily a risk-free operation. But when I take a medication, especially if a patient is having troubles with one medication or a patient is not being treated, definitely looking into mood disorder as a comorbidity, meaning as an accompanying disease, is important. And yes, of course, I'll try to pick medications such as Lamictal. It's a fantastic mood stabilizer. Depakote, of course, for the appropriate case. Even carbamazepine or Trileptal. Trileptal and Lamictal are really, really good and widely used by psychiatrists for mood disorder.
Okay, great. Can you talk about the different types of psychotherapy that can be effective for mood disorders?
Yeah, and I'm not too experienced with that, but there are a number of psychotherapies that can be used. We have some patients that we send for individual therapy. We have a few patients that have done psychoanalysis. We have patients doing cognitive behavioral therapy, which is very useful in patients that may or may not have also non-epileptic seizures. But in general, I find that counseling is important for patients precisely because we're dealing with a number of social issues related to both depression and epilepsy.
Right. And how can people with epilepsy find a therapist or counselor who has experience with both mood disorders and epilepsy? I know we get a lot of requests for that, and it's very hard to find out and have that special combination of experience. Yeah,
unfortunately, it is hard. I think it comes down to talking to your doctor and to your doctor's office. Most of us know a few counselors in our area that have that experience, that know about both diseases and cognitive behavioral therapy. So I think just approaching the office for help with that is important, and you guys, the Epilepsy Foundation, of course.
Okay. So what are some lifestyle changes or day-to-day coping tips that can help with managing mood disorders in the context of epilepsy?
Just like treating mood disorders in the general of epilepsy, so for me, importantly, I think exercise plays an enormous role. What we advise patients is to exercise for at least 30 minutes for at least 5 times a week. And that could be as simple as walk around or exercise on a bike. Some people have talked about aerobic exercise. I think it doesn't matter as long as you're exercising about 5 days a week. Exercise goes a long way. Some studies have shown that maintaining the exercise level is almost as effective as taking antidepressants, and I'm not suggesting you don't take your antidepressants and exercise, but I think it goes a long way. Maintaining an adequate sleep schedule is also important. A lot of times patients are exhausted just because they have insomnia one night and then sleep during the day, and then your schedules all turn around. I talk to patients a lot about relaxation techniques and coping with stress. And I think there's a variety of things that can be done. Some patients have done things like yoga or Tai Chi exercise through their YMCAs or through local clubs. Some patients have told me that they have gotten tapes for relaxation from local libraries that have been very useful. I actually tried that myself I had a little insomnia last year, and that worked beautifully. Social engagement is important. trying to maintain social contact with your peers, family, etc. I also think that for some patients that are involved in a sort of in a church or religious organizations, maintaining that contact is important. And I think having that sense of purpose on control of your life is definitely important.
Right. Okay. Are there any complementary therapies, either dietary approaches or herbal therapies or other types of complementary therapies that may be helpful for mood disorders and safe for patients with epilepsy? Obviously, we don't have enough information on that because they're still complementary and they're not studied well enough, but are there any that might be worth trying and any that should be avoided?
Yeah, I think for dietary approaches, we simply suggest an adequate and organized diet. I'm not going to talk about diets for epilepsy, but eliminating highly processed sugars, highly processed foods, and complex carbohydrates is usually a good idea. Sugars peak, you have insulin changes, that can produce mood changes. So eliminating some of those foods, I think, is important. Keeping an adequate meal schedule is also important. In terms of herbal therapies, I think, Rose, you're right. I think we just don't know enough about them. And there's some evidence that some very mild herbal therapies, could be harmless, like valeriana root and things like that. Unfortunately, what I think we find most today are compounds that have a ton of herbs and things in it, and it's hard to tell which is which and what is going to help and what's not going to be useful. So I tend to try and stay a little bit away from that until hopefully the FDA regulates this a little bit more and we have more knowledge. We do know that some of them are not beneficial for patients with epilepsy. And for instance, St. John's wort can lower the levels of oscarbazepine and other medications metabolized by that same enzyme system. So they can, in fact, be dangerous because you may start taking it and have a breakthrough seizure because your levels drop. Right. I think the bottom line is, and this is what I tell my patients, before you start taking anything, give us a call. We have pharmacies, and every neurologist's office will have the same sort of resources. We run it by our doctors in pharmacology, by our pharmacists, and at least we give you an idea of these may be safe, these you should stay away from.
Okay, great. And before we open it up for questions, there's a lot of debate as to whether anti-seizure medications actually increase the risk of suicide. I know there's the black box warning, but I've heard some people say that that may be more due to the fact that people with epilepsy are more likely to be depressed than the direct relationship between the anti-seizure medication and the suicidal thoughts. But can you talk a little bit about the risk of suicide in people with epilepsy who also have mood disorders?
Yeah. So I'll tell you my point about this black box warning. As you know, this came about because of a few patients being treated with antidepressants committed suicide. These were not necessarily patients with epilepsy. They were patients that had severe depression. And it sounds like what happened is that as they were treated and they started feeling better and got more energy, they carried away their plans to end their life. So that prompted an investigation by the FDA. You may remember the congressional hearings, and that led to the black box warning. Why are seizure medications in it? Because many of them are used to treat mood disorders and bipolar disease, like we said earlier, lamictal, carbamazepine, trileptal, etc. So all seizure medications get sort of put together in that group. Do we know for certain how this affects our patients with epilepsy that may or may not be depressed? We don't know. We don't know the answer to that question. But I can tell you that what this has done is that it reminds us that suicide is a complex problem in our population with epilepsy. And at least 1 in 10 deaths in patients with epilepsy is due to suicide. It's a serious problem, and we need to be reminded of that. And I think that it is a comorbidity that we see and that we don't talk enough to patients. So what I think this black box warning has done is at least remind us that, yes, we need to talk about it, that it may not be because of this correlation, but it is a serious issue. So I think it's more common in patients with epilepsy. And like I said, it's depending on what study you look at. I do wonder if 1 in 10 deaths from epilepsy came from a conglomerate of studies that Dr. Kanner studied. As you know, Andy Kanner is an internationally renowned neurologist and psychiatrist that has studied extensively the relationship between mood disorders and epilepsy. So this was sort of like a meta-analysis. So, this is something that patients should talk to their doctors. You should wait for your doctor to ask you if you have thoughts about death or ending your life. If you feel that way, you should express that. For those of you who are caregivers, asking the question, making contracts, bringing it to the attention of your physician is actually really important. Avoiding medications that can lead to overdose. I mean, a lot of times we give medications to patients for rescue, for instance, Ativan, Valium, et cetera. We need for caregivers and patients to understand that they need to be used judiciously, and if there is a question that patients may overdose, we may want to restrict those medications. But I'm glad, Ross, you brought this question, because I don't think we talk about that.
Right.
Mm-hmm.
Okay. Well, I wanted to open it up for questions, so let me unmute everyone here. Okay, does anyone have a question for Dr. Tanner?
Yes, I'm Kathy Love.
Okay.
Hi, Kathy.
Hi, Dr. Tanner. Thank you. It's been very helpful. Back when you were discussing the risk of taking certain, you mentioned some that had very low risk, but I didn't catch the ones that you said were not recommended because they had a higher risk.
Oh, yeah, correct. It's actually Wellbutrin.
Okay.
Okay, and the other name I mentioned was just a generic name for it.
All right, very good. And I had one quick second question, if I might. At the very beginning, you mentioned the 3 major depressive disorders. That would be major depression. Bipolar was the other, but is it dysthymic?
No, dysthymic. D-Y-S-T-H-Y-M-I-C, dysthymic disorder.
Very good. Okay, thank you so much.
You're welcome.
Other questions?
Hi, this is Scott Terry. I've got a question, Dr. Tanner.
Yes, go ahead. Thank you for that.
I know nowadays we're really trying to push patients or to get patients seizure-free, and I was curious, if you can get somebody completely seizure-free, well-controlled, is there a significant drop in mood disorder rates, or is it still kind of the underlying disease is it still present?
Yeah, that's a good question. I think some patients definitely improve after they are controlled. I think depending on what medications patients take, some patients might persist with some symptoms. And these are tough patients because they may be afraid to bring that out to the attention of the physician, or be afraid that their medications will be switched and they may have seizure recurrence. These are also the patients that if they persist with these symptoms, then I might want to send to a psychiatrist, because that will tell me that they need a little bit more aggressive treatment for the mood disorders.
Okay, thank you. Actually, I guess on the flip side, if, let's say, somebody wasn't seeing a doctor regularly or not seeing an epileptologist like yourself, and they were going 5, 6, 10 years, something like that, with poor seizure control, are they going to be at quite a bit higher risk then for a mood disorder?
Well, again, I think we see that in a higher number of patients, and definitely uncontrolled seizure is a risk factor for increasing that number. So we think that especially if there are seizures of focal onset, of temporal lobe or frontal lobe onset, yes, these patients might be at a little bit of a higher risk for continue to have depression and mood disorders.
Okay, thank you.
Yeah, thank you.
I have a question. I'm Marissa Morgan.
Hi, Marissa.
Hi. How much of the environment, such as like our families, jobs, and et cetera, is a cause of depression connected to epilepsy, depression?
Well, I think that plays a huge role. There are situations in which we may not necessarily see depression. We see things such as adjustment disorder, in which you have changes in your environment, and that leads to transient symptoms of depression. We can see that very often. But just for depression in epilepsy, I think your social surroundings play also a tremendous role. And I think that's unfortunate that it happens maybe a little bit more in patients with epilepsy. As we mentioned earlier, more patients with epilepsy may become more isolated. I think some patients may have, a lot of patients are fortunate enough to have, very supportive families, but sadly that's not the case for all patients. Some just may feel that they have lost independence, that their work situation is hostile, and of course that plays a role. And that's where learning coping mechanisms is important, because none of us can really lead a stress-free life. And we can try and remove some of these circumstances, but not all of them. So I think it's a little bit of picking your battles, but also learning how to cope with stress, how to delegate, and how to be assertive and be able to change some of these circumstances.
Okay, thank you.
Yeah, and in relation to that, for everyone, I just want to mention we do have a program called Project Uplift, which is an evidence-based depression self-management program. It's an 8-week phone-based program for a small group of people with epilepsy. We're doing one right now, but we'll be starting another group in July. So if anyone is interested in that, certainly give me a call.
That's an excellent program, indeed. Yeah.
Other questions?
Yeah, I was wondering if it could be possible if a person allows themselves to feel more pain. Like I made a conscious decision years ago not to hurt other people. Could that possibly be an effect on depression and blackouts?
I'm not sure I understand the question.
Well, I made a conscious decision when I was 6 years old not to hurt other people, to do everything I could. And as a result, I felt more pain.
Okay.
Because I wasn't as defensive.
Right.
And I think that's what led to my blackouts.
Okay.
I mean, most of the time, a lot of times after years of doing that, I wasn't as focused. But I felt like I was taking on negative energy that was around me.
Correct. I think it would be hard for me to tell you whether that's related to your spouse or not, but, I think certainly, sitting down with someone such as a counselor, sort of a non-involved party, someone not arbitrary, and talking about these feelings that you just expressed would be important. I mean, I can see that if you, first of all, I think it's admirable that you made an effort not to hurt anybody else, but it could have been that by doing so you became less assertive for yourself, and that you, even if you didn't want to, ended up being the subject of some, for instance, bullying or something like that. Could that result in symptoms of hopelessness and depression? I'm sure it can. And so this is exactly where counseling would be a perfect tool, where you can maybe try to figure out why this is still bothering you and why it's still producing symptoms, and find ways to go back and deal with this in a healthier way that you don't have depression.
Well, I just wanted to say I'm doing much better because I realized that I had become the family scapegoat, and scapegoats in many situations because of that. Because I was kind, I think people look for that, not necessarily consciously, to bully. And I became aware of that consciously, and so I don't allow that anymore, and it's made a big difference.
Yeah, I think that's good. And so I would suggest, like I said, this is exactly where counseling could be really, really useful to help you move to the next level. And I'm glad you're doing better.
Thank you very much. Thanks.
Any other questions?
I have a quick question. Thank you for your presentation. I really enjoyed it. I wondered, in your opinion, if you're seeing your neurologist and you think, I actually have a child with epilepsy, 17, she's seeing a psychologist. In your opinion, is at what point do you go to see a psychiatrist versus psychologist? And right now she's not on any medication to treat depression. It's mainly just visiting the psychologist and seeing them. Do you think that's an appropriate approach? I mean, so far it seemed to be effective.
I think it is, and a lot of times we start with that. I would say that if after several months your child continues to have the symptoms that you were worried about initially, then I think it's a good point to talk to her neurologist and say the counseling is working but not so much, so then it might not be a bad idea to then think about other therapies or medication or a referral to psychiatry. But if it's working, I don't think you necessarily need to jump to see a psychiatrist.
Okay, thank you.
Mm-hmm.
Okay. Do you have time for one more quick question, or no? Should we wrap it up?
Yeah.
Okay.
Mm-hmm.
Well, I had a question about vagus nerve stimulation and surgery and the effects of those on depression, because vagus nerve stimulation was actually purported to be helpful for depression, although there was some controversy about the study that did that. But then also surgery can either increase or decrease it. Can you just talk a little bit about surgery and VNS and their effects?
Yeah. As you know, the VNS was approved for the treatment of depression. And I think the numbers, as you indicated, have been a little mixed. I think we definitely see improvement in some patients. I definitely talk about that in patients that are going to be implanted with a VNS as an added sort of bonus, but I have not always seen it, and that's where it can be a little mixed. In regards to epilepsy surgery, I'm glad you asked, because we do see a couple of things. Something that we've seen is sort of epilepsy depression that starts completely anew after epilepsy surgery. And we call that de novo depression. We have more in patients that already had a history, maybe in the past, of depression, but even in patients that didn't have any depression, we've seen it. And the numbers are high, I believe 20 to 50%. We'll see that. The good news is that some of these patients get better, and usually within months, usually 6 months. But some of them do, need to be treated. We don't understand the mechanisms behind it. We know it has to be related to the epilepsy surgery. But also I think with some of the pressures related to having epilepsy surgery. The circumstances after epilepsy surgery are unique. A lot of patients have had seizures for a lifetime, and if they're seizure-free, there might be enormous pressures to return to work, to return to driving, and going back to that can be very, very stressful. So we do see that, and again, a lot of patients won't come up and say it. So I think, again, be your advocate, bring it to your doctor. I always talk about that after epilepsy surgery. Okay,
great. Well, thank you so much, Dr. Tanner, for your time, and thank you, everyone, for participating. It was very enlightening, and we'll have another Learn and Share call next month. So, and like I said, if anyone is interested in Project Uplift, please give me a call. So, thanks again, Dr. Tanner, and thanks, everyone, for joining us.
Thank you. Thank you.
Thank you. Thanks for the chance.